All right, thank you so much. We have a fantastic group here today to talk about the trigeminal guidelines. Again, today our focus is a facial pain association. I'm David Darrow. I'm a pain and functional neurosurgeon at the University of Minnesota, and we have a fantastic group today. I'll let everybody introduce themselves. Anna, if you want to start first, you're next on my screen.
Sure. I'm Anna Williams. I'm a patient with lived experience of trigeminal neuralgia, as well as I do patient advocacy in the headache space. And I live in Indiana, down near Louisville, Kentucky.
And Melissa?
I'm Melissa Baumbick. I am the CEO of the Facial Pain Association and am here to represent the community that we serve.
Dr. Holland?
I'm Marshall Holland. I'm a functional and pain neurosurgeon at the University of Alabama at Birmingham.
And Dr. Nixdorf.
Hi, my name is Don Nixdorf. I am a dentist or facial pain specialist in Minneapolis, and I am a member of the Facial Pain Association's Medical Advisory Board, so I represent that perspective.
All right. Well, thank you all for being here. Our focus today, as we've talked about, is on this initiative to form the first ever surgical guidelines for trigeminal neuralgia. Obviously, Marshall and I are trying to represent our joint section, the pain section, which is a combination section between the AANS and the CNS, our two parent organizations. We're a small but rowdy organization, trying to do the right thing and have some actual guidelines. So I think, our most important question is really to kick things off with Anna. What do you think of our PICOs?
I think patients really want this. I think we want to know that there's steps and guidelines and that there's evidence behind it. I'm really looking forward to this because I know as a patient, once you get the diagnosis of trigeminal neuralgia, it's like, okay, so what next? What do I try? What do I do? In what order do I do it? Like, these are all the questions, but a lot of times patients are overwhelmed and they don't know what to look at or what to ask. And I think guidelines being out there is a great place to start.
Can I add something? I think that having guidelines for physicians would be really helpful as well, just in the sense that, because this is a fairly rare condition, there are a number of physicians out there that are not aware of the options that come after the medications, or even of all the medications that are available potentially to try and manage pain. So we hear from a lot of patients that that they are receiving guidance to a certain point, and then they sort of get left and there's nothing to move forward to. So having a set of guidelines and steps to help them move through that, even if they're the ones bringing those to their physician, I think could be extremely helpful.
Yeah, that's a really good point, Melissa. I think one question is, because I think what we've all experienced is that there's a lot of heterogeneity with treatment algorithms, and I don't think any of us have, the exact answer for a lot of the questions that patients ask, but having guidelines to work off of, provides sort of a little bit of a roadmap to start somewhere, and sometimes guidelines show that there's really not any difference between, things, and sometimes it shows that there is a clear difference. But I think starting the conversation, at least, so that there's a way forward for people to, start talking about, how it interfaces with the diagnosis guidelines, for example, which is a, ongoing process between a few different organizations. And then also the fact that there are so many different groups involved in, facial pain, right? We got, every variant of medical and dentistry involved in just trying to figure out what the heck kind of pain people have. And then, then there's just the extremes from, having a craniotomy for surgery versus only being able to have medication. So it just spans essentially, everything, which makes it challenging to, sum it up into really, easy, concrete evidence that everybody knows about. But that maybe that's part of the value as well.
Yeah, I would second all the things that have already been said. What I find is that patients, they seem to have like a confusion or fatigue on making decisions, and are asking, well, how do you know, and those type of things. And obviously this is a step in that direction. I won't answer all of them, but to help guide some of the decision making, I think is really helpful.
I think one of the opportunities here is, even for the things that we don't have clear evidence for, at least that's out there now, that you can have an honest conversation with the patient, say, this is where we have solid evidence, and here's where this is more my practice or my opinion or practice patterns that we see. I think that having that honest conversation, knowing that that document was, and that evidence was thoroughly looked over, I think that's really important.
So one thing you'll notice, I think, is in the PICOs that we have, we're really trying to break it down to just the absolute simplest comparisons that, I think patients want to know. Our first PICO is focused on, whether or not we look at MRIs versus whether or not we're just listening to patients, because I think what's really confusing for both patients and clinicians is that the symptoms of trigeminal neuralgia are one thing, and the diagnosis of trigeminal neuralgia is another thing. And these things are quite confusing. As we know, people can have the symptoms of classic trigeminal neuralgia due to many different problems going on. Most famous is neurovascular compression, but there's tons and tons of reasons, like having a tumor or having multiple sclerosis or TMD. People have the symptoms of trigeminal neuralgia all the time. And that is very different from, the various etiologies. And so we have been trying to walk a fine line to sort of illustrate that without talking too much about diagnosis, because we're focused mostly on surgical guidelines. We just have to make some assumptions about, diagnosis to talk about surgery, obviously, because of, it's hard to decompress someone that doesn't have any compression. Mm-hmm. And so most of the rest of the PICOs are really focused on comparing all the different techniques that are the most common techniques that people use. And we picked the ones that perhaps are, most commonly used in the United States. There are, others, but these are the most commonly used. And it's interesting because I was looking back and reading some of the early work that was happening with Janetta, and looking at some of their outcomes, and it was very interesting because the procedures that they were doing were really just cutting the nerves. It was pretty wild. So seeing where we are today is pretty significant change. And then I think one of the last few PICOs, like one focuses on repeating the same procedure or doing another one, because that's like a pretty common question that people have asked me is, when you're not cured by MVD, or you still have pain, or MVD wasn't an option, should I just continue to have the same procedure every time my nerve heals up? And so we've been focused a little bit on trying to answer that question, or whether or not there's any differences in modalities. So those are most of the PICOs. The last couple focus on tertiary therapies when everything else doesn't work. And then the very last one is focused on whether or not, when you have a procedure like an MVD or a rhizotomy, should you just stop medications really quickly, or should you wean off after some time? And that's kind of that's sort of the ballpark that we're playing in with the PICOs right now.
I think those are excellent questions. I would say that from my experience with patients, there's a lot of questions around surgery versus some of the ablative procedures and the order of those. And different doctors seem to have diametrically opposed opinions on that. And so it's difficult for patients to be able to wade through that with the level, even with their research and with the level of knowledge that they have. So in if there is a way to establish something that sort of gives them that order, I think Anna mentioned that it is really, that would be something that would be incredibly helpful, I think, for people trying to figure out what to do next.
So is that a goal, to have some sort of hierarchical rubric about how to move through this for patients? Or is it just answering the questions yes, no, and then you have to piece it together?
I think, yeah. So the first line that will come from the questions is just the direct comparison and effectiveness, right? And that's complicated because most of the time people come into each procedure with different biases about where they come from, right? So that's a challenge that we face with evidence. I think, physicians, and especially surgeons, have some pretty strong opinions. Mm-hmm. And they have strong opinions for a good reason. They're trying to, minimize harm to people. It's just that, unfortunately, part of being human is that we see harm in different ways. And that's one of the really important things about having a diverse group of surgeons. We all sort of conceptualize harm. For example, people have made the argument, and it's perfectly fine, that as the gold standard, MVD should always be offered first, no matter what. And I think a lot of us know that the outcomes from MVD are really good. And other people have made the argument that it's perfectly fine to start with an ablative procedure if you're really worried about surgery, because generally speaking, the nerve will grow back, and most of the time you still have the opportunity to do a microvascular decompression. It's a little mixed for gamma knife, but people recognize that sometimes you're at a place in your life where you don't have the psychological space to take on a brain surgery, and that's okay too. And so there's lots of ways, I think, and that's why it's so important for us to evaluate these tools. A lot of it's just based off of, how you feel about risk and your risk tolerance at the time. And there's not necessarily one right answer. So to answer your question, Don, I don't think guidelines are ever going to tell everybody sort of the sequence of events that should happen or should not happen for their treatment, because the underlying research would really have to go after it. There's a tiny bit of data about sequence of procedures. But I do think it lays the groundwork for us to be able to talk about it, because one of the things that we do when we're looking at not just the outcomes, but also the risks associated with the procedures, is be able to sort of talk about their relative, risks between them. That's a big goal. It's not just the outcomes, it's the relative risk. And so that I think plays a significant role in the discussion, with patients.
And I think another part to it is when patients are considering some of these things, they're in a really bad way.
Right.
They're in extreme pain. They're not making some of the best decisions. Usually they're maxing out on the medications with side effects. And that's like the recipe for the worst time to be making life or death or major decisions. And so how is that going to be taken into consideration in these guidelines type process?
Yeah, that's a great question. Not an easy one.
I've come with a couple of things I wanted to get out here from the patient's perspective.
Yeah, I mean, to some extent, it's sort of a little bit of a disservice that we're not talking about medications in here, because, when you're considering surgery, you're weighing surgical risk against the long-term risk of medications. And that's really hard because, surgery, you have big risk up front, you have some long-term risk as well, but you have big risk up front. With medications, it's mostly a long-term risk thing for the most part. And so you can't even think about it exactly the same way. Unfortunately, I think, at least in this version of the guidelines, we will not be getting into, the psychology behind how these decisions are made. But on the medication side, that feels like a pretty, talking about the side effects of medications plays directly into sort of those, what you're talking about. I'm trying to imagine how we could tackle it sort of as a community between the guidelines, because I think that's the real struggle.
Yeah, I would think you probably need to get to the point where you have medication guidelines and surgery guidelines and diagnosis guidelines. And once you have those, then you'll be able to get to the point of discussing them all together. And maybe even bringing in the medical ethicist aspects of things and the statisticians about, okay, how do you quantify risk and harm?
Right.
And within the patients, like when they are that desperate and pain, right? And they want that MRI to show the compression. They want to see the reason for the pain. And, you know, you see in media, you see the latest TV show and someone comes into the ER screaming in pain and the doctor goes, oh, it's trigeminal neuralgia, and they rush them into an MVD and everything is glorious and great from there on, and the episode ends, everyone's happy. But it's not quite that easy, right? Like the diagnostic process should be extensive, right? Before you start talking surgery and everything, but sometimes that MRI doesn't show a compression. But then also when the patient's desperate in pain and a physician says, hey, let's do surgery, are they comprehending at that point the expertise of the surgeon? How many MVDs has the surgeon done? How many gamma knives has the surgeon done for trigeminal neuralgia versus a tumor or something else? So like that's difficult too, because we don't all have access to the same physicians and the same expertise either.
I mean, yeah, that's like a role, that's like an amazing role that the FPA plays, I think. You know, because for all the rare diseases like trigeminal neuralgia, you know, you get diagnosed and then 5 years later, you know, a bunch of people that have trigeminal neuralgia because you're here, you know, you've heard about it, it's in your brain, but most people don't know anyone with trigeminal neuralgia, you know, when they first get diagnosed, and they are completely alone. And that's just devastating for multiple reasons. And you're just in so much pain. And so you hope that you're around, you know, people that know at least how to treat it medically. And even that can be really challenging, you know, it's just absolutely awful.
It is. And that is something, you know, that we continually try to, you know, help people manage, even in providing guidelines about questions they should ask their doctor, just trying to put everything out there, because with the primary understanding that these people are in pain. And so as much as we can just put right in their hands that they can use without having to, you know, search high and low, you know, but that's why awareness is so important for us. But one of the, another, you know, question that we really hear a lot is with, you know, the longevity of the treatment and how long is it going to last. So I don't know if that's a goal of this as well, is to understand, you know, and be clear about when something is maybe more invasive, but probably a longer term solution, and something that might not be as invasive, but is likely shorter term. You know, it's hard to tell people that when they've already made their decisions, if they don't have all that information. But, you know, we are not, as non-physicians, the FPA staff, really in a position to always communicate that. So it would be great in that sense to have guidelines that talked about that as well.
Yeah, I think that's one of our biggest questions in forming the guidelines, is what evidence is out there for that. That durability of the procedure, is that, as Dr. Darrow was saying, different patients are going to have different internal risk profiles. What is risky for me versus someone else?
Yep.
Then they can make their own value calculation based on, here's what the evidence is for the durability of that procedure.
In the guidelines, is there anything about the time between procedures?
A little bit, yeah. Maybe not like, you know, it's probably not going to be like how long you should wait, but inside the question about repeating the procedures, there might be a little bit of evidence about, like how often people are getting the procedures to, basically have the same level of pain control, if that's what you're getting at.
Yeah, kind of, because I've, being in the patient community, I hear a lot of stories, and someone will have a procedure and it may provide relief, and then maybe 6 weeks later, something happens and the pain is back, and they're in that desperate amount of pain and they want the same procedure again or a different procedure. And sometimes it starts mounting up quickly. And so I don't know if that is talked about in there or not, but is there ever a time to press pause? Like, does there need to be a pause button between procedures at any point?
Yeah. There's going to be a little bit about that in the discussion on the percutaneous ablative procedures versus gamma knife. Primarily because of the time constants for radiation, and so there's going to be a little bit of talk about sort of a pause on treatments during that time period. I don't know if we'll be able to address that super comprehensively, but I think there are going to be pieces of that in both the sixth and the fifth question addressing that. But I'll make sure that we see if we can comment from the literature from both of those.
As you were alluding to, David, one of the ways to look at it is what's the minimum amount of time that you need to be able to determine whether it is a success or failure. That's a great
option. Yeah,
I think that's what Anna's getting at.
Yeah, and that also comes up in that like structured medication wean, question, that last question a little bit, because it's a little bit tricky, but maybe we can spend a little bit of extra time looking at the rate of change of failure in some of those publications. That might be one way to address that.
Yeah, I know in ICDH, I think it's ICH3, I know in ICOP, there is for the neuropathic pain secondary to trauma, there is a time frame of onset of pain after a procedure. I know because of my participation that is an estimate. It's not a database at this time. And so anything that you guys can come up with to guide that would be helpful.
Maybe that will change with the new ICOP. I don't know.
No, just because we don't have good observational studies on that side. I think in your discipline, you guys are purposely injuring nerves. And so by that aspect, the start and stop time, and you have an observation. And so you may be in the best position to comment on that.
Absolutely.
I have some questions related to PICO 1 from a patient perspective.
Sure.
One is that, as Anna alluded to, patients are hoping and sometimes have strong feelings about what it should show or shouldn't show. And so it raises the question of, how do you know? Is the image good enough? And was it done by a facility that knows what they're doing? And why did that facility not know what it could be doing? And how does that, and so forth? How narrow is that question going to be, and how broad? Because you can say, okay, well, why not have someone sitting up? Everyone's laying down, and it's a static image versus a dynamic individual.
Yes. So that first PICO could become a whole guideline.
We talked about that when we started.
We did talk about that. We are not trying to make it a whole guideline because there is a lot of overlap between the surgeons and the radiologists on this, and so we're trying to be mindful. This is the first guideline. We can always add more questions and work with the radiologists more and more. I think, we had a really great discussion our last meeting, which hasn't been posted yet, but we had a really great discussion with the head of ASNR, who does trigeminal work, Dr. Malhotra. And I will say that despite, Dr. Holland here trained under Dr. Marshall, who is like very well known for a lot of the work he did on confirming and validating the imaging side from the surgery side, which is like, a very difficult process. It's a very difficult process. And so great strides were made, I would say, and really helped us understand a lot more about neurovascular compression, neurovascular contact. And there are many other people that did amazing work really laying this out. But the nice thing is that the consensus, or at least in our discussion, was that the future is very bright because the imaging quality has gotten so good. And now seeing the 7 Tesla stuff that we're now seeing, Dr. Nixdorf and I are now seeing, the images are just amazing. They're just really amazing. And so my honest hope is that regardless of what we find on this PICO, the direction that the imaging is heading is so good that I hope this will not be an issue anymore, or at least, mostly for places that are doing trigeminal neuralgia surgeries. And so I really hope this is just a byproduct of the past. But you're absolutely right, Don. There's a lot of nuance to getting good, reliable imaging that can be definitive, I would say, about neurovascular compression. And so that's our intent, is to talk about that versus just getting a regular screening MRI. And I think that's where a lot of the tension in our world is. If you have, in fact, we even talked about TMD as part of this diagnostic process from the MRI, which was cool, because they were saying that they can see the joints, and so they're taking all this stuff into account now, which I found really interesting. And so, will the future of facial pain diagnosis be looking at all the structure, which doesn't tell you about the function, but rules things in and rules things out, and then the rest of it being sort of the patient history, making sure there's not tumors or MS, or we talked a little bit about the sort of MS, diagnosis as well. So, are we heading in that direction so that all centers can really provide that? I think that's a big part of that. But because of how much data is out there with this PICO, I think we can answer some basic questions about, the diagnostic sensitivity and specificity of these different modalities.
For advocating from the patient's perspective, it would be good to set minimum criteria for an MRI for this. And there are a couple of reasons for it. Is one, so the insurance providers pay for it. Okay, add one. Why are you asking for another one? And then the other aspect, when you're setting the minimum criteria, take into consideration access to care and that aspect of it. I would think 3T scanners are pretty ubiquitous in major centers that are doing brain surgery, I would think. But I don't know. And I think that would be something that would be helpful so the patients know they're getting, quote unquote, good care.
Right.
Because I think that's what it's all about.
That's an excellent point. I think we can definitely comment on that.
Yep. And then the other one that I have related to imaging and that kind of stuff is like everything else, technology advances, things get better. We're getting to see some of that already. When you think about these guidelines, there's going to probably be more questions raised than answered. It would be nice to kind of set some of those out so that it's like a roadmap for other people to do research, and so that you can use this as an authoritarian body, and researchers can say, hey, the experts looked at it, and this is what they're saying is next steps, so that funders know what's a reasonable thing to go to, so that patients can get the information to fill the gaps in their decision making. And the other aspect that goes closely with that is the concept of sunsetting, or at least setting a time saying, hey, we're seeing imaging progress so much, we can be comfortable saying these are valid for 5 years, for 10 years, and then or they may be suspect, or I don't know, something like that. I'm just picking numbers out of the air. But the concept is it's not going to be the be-all, end-all forever. And so how do you put
No problem there.
Yeah.
Yeah.
That's already baked into our committee. Yeah.
Our committee is very strict now, so it's 5 years and you're done.
Oh,
Doesn't
okay.
matter what
Yeah,
you
you have to update it.
Okay, good. So there is some sunset to it. That's wonderful.
But your point about future directions and like identifying key things from the search is actually, I think, really good. And I think there are some guidelines that have done that. And so we should definitely do that, because even if we're just commenting these are current controversies, you know, we don't have any information either way, then, you know, maybe that would be helpful for, you know, funders, but also I think people, you know, who are working in the area.
Yeah, and it's helpful for patients because patients are going to read this. I think healthcare literacy is increasing with access to information online. And when they get to see that, hey, there is equipoise at this point, then that's when, and they can read saying, hey, this is where opinion and expertise and that kind of stuff comes in, and desire. And so that they can help guide that discussion.
How do comorbid conditions fit in here? So when the imaging's done, let's say the imaging is really great and you do see TMD as a factor, but maybe you see the compression too, or you find out the person has MS, or even something completely different. There's a lot of stuff going on about Lyme disease and connective tissue disorder. Like, when patients come in, we have all these specialties, right? So when we come in for a surgery consult, we're looking at neurosurgery. So we're super zeroed in. But as part of assessing surgical outcomes, we have to take the whole patient into consideration as well. And sometimes that can be disappointing to a patient because they can be like, oh, I did research, there's this microvascular decompression surgery and I'll be pain-free. And then the surgeon may go, but you have these other things going on. I'm not sure that that would be the best route. And so it can be really difficult, but I see where those are important conversations though.
Yes, it's a huge part of, you know, I think what Dr. Holland and I do, which is focused on how do we change the education on the pain side, you know, especially for surgeons. And much credit to the dentists. They've done a lot of work on really trying to take into account all these overlapping pain conditions that can play a huge role. And it's, you know, a major part of our comprehensive facial pain clinic, which is to sort of help try to figure that out. You're absolutely right. I think there are, in our literature, much less on that right now. And so that, I would say we're behind the times on, and some of that's for good reason and some of that's for bad reasons. One of the good reasons that that's true is because, you know, MBDs have pretty good outcomes. And so it hasn't been, you know, as bad as some of the other pain surgeries that have been done. On the bad side, that sort of like prolonged the, you know, how long it's taken to come around to understand sort of the dynamics of a lot of these other diseases. And so now we're really at that point where we're trying to do those, to incorporate a lot of that in the studies that we're doing now. And unfortunately, because of that, there's no literature for us to search.
Yeah.
Very little. And Don can tell you, people are not super excited about publishing stuff like this yet.
Yeah. And hopefully the world will get there. Playing off of Anna's question in a different way is, What about some of the medical conditions that may have, so like connective tissue disorders that are known to affect blood vessels and MVDs, like Ehlers-Danlos syndrome and that kind of stuff? Do you think there's data there that you could pool it to start asking some of these questions? Do you think there's data there looking at making recommendations, saying, okay, if we have like an initial contact in an Ehlers-Danlos patient and they're young, would you then say, oh, that's going to progress faster than someone that's not? Do you think the data can go on that? Or you get to that personalized care type approach?
Pretty sure Dr. Holland has the answer to this question. So.
I don't think that data exists right now. I don't think we're looking for it. I think a lot of these things, we don't know the questions to ask. We don't know what data we should be collecting. I think that Ehlers-Danlos and other connective tissue diseases fall into that. Same like David and I have talked about these families of central sensitization diseases. They're cousins of each other. And they got siloed, and now we're trying to put them back together. So it allows us to, at least the fewest that are interested in this, like I tell my patients, my nerd friends who are into this, we put our heads together and we say, what are we missing here?
Do you think a side outcome of all this would be like a list of minimum data elements to be collecting for future types of research to answer these questions?
Probably from these PICOs, no, because there won't be any literature to even like say that, it's there, or it's not, or it's not there. It's like, it's a hard thing to say, I think, but that doesn't really matter. I think if, that's what's going on with, the community and with, other literature, then there's no reason that is not just patently true. And we should do that anyways. I think one thing that this process of talking about the guidelines has done for us, and what we're really hoping will expand, is, because we're talking about comparative effectiveness here, there's a lot more discussion about registries.
Mhm.
Registry. So, super critical, important thing. But not exactly the same as we want on the surgical side, for a registry. Hopefully maybe one day they could sort of match up, and they will tell us the different perspective about what's going on. But more and more I'm hearing from my colleagues that, while we know it's a rare disease, maybe there is sort of a lower cost way for us to work together to pull patients, especially in this age of AI, especially in this world where maybe it's possible to set up AIs that can mine, our medical records at each institution and pull out that necessary data. And so that's what the conversation that's going on right now, that hopefully we'll be able to start answering those questions, so that it's much more of a dynamic process of us figuring out, whether or not which threads are big enough we should start, teasing apart, because people really need answers to them sooner than later. And so, that's, I think, the exciting part, and why these discussions are extremely helpful.
I feel like these guidelines are really going to spur that conversation and bring this together.
Yeah, I could see us as a group, as we have these conversations and go through this process, David, at the end, I could see us putting out like an editorial talking about a lot of these things that Don has brought up. Here's the things that we wish we had. Here's the things that we should be thinking about going forward, kind of as a companion piece.
Yeah, I hear the title, Our Failures in Trigeminal Neuralgia. Okay.
Mea culpa.
Yeah. It doesn't matter where you are in healthcare. I think we're always that, because we have stuff to do. And I would say, if you guys are looking at something like that, I think engaging like you guys are in the stakeholders in those type of things would be helpful too. Yeah,
no, absolutely. We'd love to have you as part of that, that conversation, publication, whatever it may be, because I think, this is where I think a lot of the future of what people are going to work on is going to come from. I think we just have to identify the tools to make it, as efficient as possible, so we get some answers, in our lifetimes here. Because I know it's not like people haven't tried. These are really big questions that people have been trying to ask for a long time. And so the only difference is that now, at least analytically, we have better tools and we have better, potentially better databases. So we can finally maybe get started, and we can always choose to collect data going forward. So.
Got it. From a patient perspective, how do patients get access to this information? How is it going to be disseminated? What is that process so that the hard work gets the airplay that it needs?
So our guidelines are published open access. If that's what you mean, Don, or did you mean? Okay. Yeah, I think so. We have a journal that basically has agreed to publish the guidelines from our guidelines committee no matter what. And so they publish guidelines pretty regularly so that people can access them. I mean, I wouldn't say they're like the most thrilling read, but like I think we could make some like snippets of it a little bit more engaging and talk about like, what we know, what we don't know sort of stuff. But I think it will be very accessible from that perspective. Getting it out there and marketing guidelines, that's like a whole new sort of thing. And especially not just for the patient side, but on the physician side, getting the guidelines read is a big endeavor as well.
Yeah. And Melissa, I would want FPA to seriously consider like doing news pieces where you have like
exactly. That's what I was thinking, that we could help with that. We would want, our MAB, I guess, to review. I mean, is there a place for that, or is it just, the FPA? I don't know. Generally,
so typically what we do, and we do this for other organizations' guidelines, is we choose to endorse or not endorse based on their methodology.
Yeah. And
our methodology is super nice these days. It's very clean and clear, and it's quite rigorous. So, I think Marshall and I will stand by our methodology, no problem. But once the guidelines are done, we'll send them to you, and you can choose to endorse it, with your medical board or not. Some of it's for other reasons, but I think it would be, pretty straightforward based on these guidelines. Or you can just choose to advertise that we have guidelines. Like, you don't have to necessarily endorse it.
Well, I think as I said before, that I really think that having more information as opposed to less is going to be helpful for people. And so I do think going through this process, and I don't see why it wouldn't get endorsed, but I think that we can absolutely help with getting the word out. And I think we could do a myriad of different things. And I think it would be very well received by the patient population.
What I would think would work is have patients put it into like a summary for patients, and just have people from MAB just make sure that that's factually correct from what it's taken from, so that opinion of the MAD doesn't get in there, because it's supposed to be guidelines in that process.
Yeah, unfortunately, that is the hard part about guidelines, is sometimes we don't have any answer, and it just says we don't know.
That is an answer, though.
It is an answer. It's like, we don't have enough studies. But I think for most of the questions, there'll be a reasonable answer, and I think it'll be a good start. The timeline for the guidelines is that we're hoping to start this summer, and we have our guideline committee gives us 1 year approximately to finish the guidelines. We're anticipating there's going to be a lot of papers, like upwards of 10,000. So we're going to try really hard and put together a good group of people who can get through them, but we think it will be worth it. So we're cautiously optimistic that in a year from now, we'll be pretty close to having the first version ready.
Be amazing.
It will be. I think dissemination is really important, and I feel like it's going to be really helpful and hopeful for the patient population. And I mean, once I get a hold of it, I'll be for sure pushing it out to the patient community that I'm a part of, and helping them sort through it and understand it, and get it into, maybe most of them can read it, but help them understand things that they can't. But
should be very readable. Just
that's what
boring.
I'm thinking.
It's very boring.
But sometimes just highlighting,
Yeah.
hey, go to here. You don't have to read all of it, but
Right. Yeah, sometimes they push it, they're very long, but it's only to be complete, not because there's much to say. But, I think the nice thing is it will provide some summaries about these sort of groups of publications that I think will be really, really important. Well, I thank you all so much for being here, and thank you so much for, engaging about this and, supporting this very glamorous cause, because I think when I realized there weren't any guidelines, I found that kind of surprising, considering sort of where we are with treatment. So I think hopefully we'll be able to do justice to that.
What are the next aspects of where stakeholder input or activity is related to this process that you guys are going through?
So, the first question is, are we missing some categories here of things that we can answer? And I think that's kind of like what we're hoping to get today. Like, is there something surgical that we really need to incorporate as a separate category of PICOs? Or is it the tweaks that we sort of were talking about today? The tweaks are pretty straightforward, I would say, for the literature that we can find. But I think we just want to make sure there's not something major that we need. And then the second part is, so let's say we get these guidelines done. We only have 5 years with these guidelines, and we're going to be back to doing it again. And I think our goal is actually expansion. It's not just, redoing the exact same search again. Of course, we can do that again and see if the evidence has changed, but I don't think it's going to change on MVD versus Gamma knife, So it's really going to be adding categories and more questions to help refine things more. And personally, I think it will take, a year or two of dissemination, of people getting upset that we didn't address something or whatever, and then adding on these are all the things that we forgot, let's get ready for the next guidelines, and then putting either, are we going to do a whole separate guideline, that is categorically different, or are we just going to double the number of PICOs and try to answer those? So that's sort of how I see. And if this happens every 5 years, I mean, gosh, we've been doing MVDs for 50 years or whatever. I think we'd have a really good idea about, what the goals and how things have changed. And, I think a lot of things are not going to change in 5 years, but to your point, Don, the imaging, maybe the medications, because there's a lot of stuff going on in the medications world that we could interface with. And the other thing is, I think talking with a lot of the societies, they're thinking about guidelines now, so I'm hopeful that it will spawn more conversations about standardization and guidelines.
Thank you.
Yep, I think that would be great.
yeah, thank you. I appreciate it.
Thank you for that work. I mean, thanks to both of you. I mean,
Yeah.
Thank you so much
for your feedback. That's helpful.